Looks like people are joining, and so we'll go ahead and get started. So today, welcome everybody to our webinar on school-based telehealth for building healthier communities. I want to introduce you. I'm Carrie Souza. I'm the moderator. I'm the VP of Marketing here at AMD Global Telemedicine. And today I'm joined by Tiffany Griffis. She's the Chief Executive Officer at Eastern Oklahoma Medical Center. Welcome, Tiffany. Lisa Patch, who's the Executive Director of Health Services at Alamogordo Public Schools. Welcome, Lisa. And Thomas Kemp, he's the AVIT Project Manager for Solutions. Welcome, Tom. Okay, so before we get started today, I thought we'd just kind of quickly take a quick poll to help understand kind of where everybody's coming from, what type of organizations you all work for. This will help us in trying to tailor the presentation and the topics to you. So please indicate which type of organization you represent. Okay, it looks like everybody's answered, I think. Or close to. Wait a minute. Good enough. So a lot of you are from health systems or hospitals. If you can see the results here, 45% of you are from health systems, 9% from academic medical centers, 27% from school systems, 9% from community health centers, 0 from urgent care facilities, and a few that have been, or one was indicated other. Okay, thank you. So before we get started, just kind of a couple of key takeaways that we hope you all learned today on our webinar. First, how you can provide essential services to children in school through telehealth if you're not already doing telehealth in school and or looking to scale your program, and how it can reduce common transportation barriers to care in rural communities. And then, of course, discover how telehealth has made an impact on student attendance, improved student health, and maybe some other areas that our panelists today will share with us of different things that they have seen that might have been unexpected. And then, of course, we'll do a kind of a panel session at the end where each of our panelists can share some personal insights on how they have successfully overcome some of their challenges, how they've scaled their telehealth programs, and then, of course, address any of the questions you have today. So as with all webinars, you're all very familiar to add your questions to the Q&A section throughout. Go ahead and type them in as we're going through the webinar. We'll be happy to address them at the end and or maybe in between. If there's time, we'll also maybe feather in some of the questions. So feel free to type in any questions you have along the way. Now I'll turn it over to Tiffany.
Hello, everybody. I'm Tiffany Griffis. I am from Eastern Oklahoma Medical Center. We are located in Poto, Oklahoma, which is in LaFleur County. You can see our population there is just under 50,000 people, but we are a fairly large rural county that is over 1,600 square miles. So when you think about that, we have to cover, we are the only hospital in the county. And then we are critical access. So we have 25 beds within our hospital, but we also have 3 rural health clinics. Our rural health clinics is where our school-based telemedicine program is based out of. So we run a nurse practitioner that is our provider that takes care of our kiddos. And we are in multiple schools within our county. So when we started our program back in 2018, so we've been at it for about 5 or 6 years now. When we started out of it, our goal was to be in all 17 counties or in all 17 schools within our county. We haven't quite made it there yet, but we're making good progress. We're currently in 14 of those, and you can kind of see those listed on the slide there for you. So we're in 14 of those. But we also have recently added our local state college, Carl Albert State College, which actually has 2 sites. They have one site here in the county and then one site in the county north of us. And then we have one school that is out of the county that we provide service to. So we have grown. We're currently in 14 sites within the county out of our 17 school districts. So we're working on it, and we're almost there to make it to our goal. All right, so getting started as far as our program and kind of how it impacted our students and faculty and families, kind of the biggest piece of it was our access to care. Um, Carrie, did you want to go to that next poll? Sorry.
Yes, I was gonna say, that's okay. We take a quick pause before we go into that. If we can just launch a quick poll so we can get a gauge of who has current telehealth programs and if you have any school-based telehealth programs. So we'll go ahead and launch that next poll. Okay, so do you currently have a telehealth program? You should see that question pop up. And this will help, Tiffany and Lisa kind of address different elements of their program based on your current status. So 80% do have a telehealth program and 20% said no. So we can go to the next quick poll, dig a little deeper to understand if you have a current telehealth program in a school-based application. Okay, to the next poll. Let's give it a few minutes. Okay, we can share the results. It looks like almost split. 53% said they do have a school-based telehealth or telehealth program in a school-based setting, and 47% said no. So you're right, almost down the middle. Okay, great. Good. Okay, Tiffany.
All right. So again, our program launched back in 2018, and we did a lot of research into starting these school-based telemedicine programs before we actually decided to go ahead and implement it. Some of our research that when we were doing it, looking at different programs across the US, showed that 90% of these visits that were in urgent care could be completed in a telemedicine clinic. Of course, our goal was to be quick and convenient for the patient. This all kind of corresponded to some of the social drivers of health with access to care. That's a big piece, especially in a rural population area. The majority of our patients that we serve are Medicare and Medicaid, so a little bit lower on the socioeconomic aspect of things. And a lot of them just don't necessarily have access to care, or a lot of times the mentality is, oh, you'll just get over it. You don't need to go see the doctor type things in our area. So we just had a lot of things to overcome with our current population that we serve. And so we thought that this may be one way to kind of step out between or from our hospital and our clinic walls and actually get engaged into the community. So when we were looking at the program, again, most of the research that we looked at was really strictly based on the kids within the school and how it helped them, and absenteeism, increasing continuity of care or education, and things along that nature. But after we sat down and talked with some of the schools, amazingly, the teachers get sick as well as the students. So when we implemented our program, we decided to go ahead and implement or to offer the program to the whole staff. So when if someone presents to the school nurse, whether it be an educator, ancillary staff member like a bus driver, or housekeeping, or environmental services, or even the students, we try to provide the care if at all possible. There are a couple of specific diagnosis or complaints that we will not do via telemed. So any type of trauma, any kind of belly issues or things like that, just because those really require hands-on care. We decided not to do those. So those, of course, will be referred to the emergency room. But again, most of the research showed that anywhere from 89 to 98% could return to class of these visits. And then, of course, 90% of what was seen in a pediatric clinic could be completed via telemedicine. So our results from looking back at our different visits pretty well correspond to those numbers too. So, really kind of our goal in this is to decide whether they're infectious or not. And if they are, then we need to get them sent home. But the other thing about it is we can get them seen, we can get them diagnosed, we can get them on medications quicker. And so that way they can return to school quicker too. So it does, while they may have to go home, it does decrease overall absenteeism. The other thing that we looked at is so schools, monetary incentives, they have those in place. So if their absenteeism is a certain level, then they actually get paid less for having not as many students in class that day from the state. And so we could bump those numbers up. That would help the school's bottom line along with it, along with the teachers. If they're not having to pay a substitute, it kind of keeps the continuity in education for the teachers to be in the classroom more often. So I don't know about you guys, but when I had a substitute teacher in high school or elementary school, it was more of a play day for us than it was a learning day. So if we can keep those core teachers in class, it helps the student, it helps the school, and we've done our job as a healthcare facility. So those were kind of the biggest things that we really looked to impact when we started our program, and so far it's done really well, and we've had good success with that. Some of the barriers that we looked at that, as far as implementing the program that we were wanting to work on, of course, access to care, the transportation piece of it, but also access to the medications and then medication adherence. So with this one, I'm not sure if you all are in a rural or urban areas, but we're rural, and there's a lot of towns in our area that don't have pharmacies, or there may be pharmacies in town, but the parents or grandparents can't afford even just the gas money to take the child to the doctor or go to the pharmacy and pick up the medication. So these are several instances where we really come into play. We've had a couple of times where our pharmacies will deliver to the school, and give the medication to the school nurse to either send home with the child so they can continue their medication there, or actually our school nurses went and picked up the medication and then just kept it at school, so they know that they're getting their 2 doses of amoxicillin every day for the next 5 to 7 days for their strep throat, so they can make sure that the child recovers appropriately. So there's several, different schools have come up with different plans in order to help us with this program, but they have really done a great job. And their goal is to get the kiddo taken care of too, just like ours. So we've done well at kind of overcoming those barriers when we first started the program that we were very concerned about. When again, during development of the program, some of the biggest hurdles that we personally faced were legislative hurdles, hesitancy of the guardians, and then school nurse buy-in. So with our legislative hurdles, we really didn't know anything about telemedicine. This was new in Oklahoma. It was pre-COVID, so it wasn't as popular or well known as it is today. But so we had to honestly do our own research as far as what the rules were on doing a telemedicine visit, because we hadn't done that before. We use some teleradiology services in the hospital, but short of that, they're not really having a lot of patient interaction or anything along those lines. So while it's telemedicine, it's a little bit, it's a little different than what we were looking to implement. So, again, back to the research to figure out what our rules said, what our law said, whether we're going to be able to get paid for this appropriately. And even if we didn't make money, at least break even, just offering the service to the community. So what we found out was the way that the laws were written, we absolutely could not provide school-based telemedicine. And so we had to enlist some help in order to get these laws changed so we could start our program. So when we were doing this, we enlisted our state Telehealth Alliance group to help us do this. And of course, they jumped right on board, and they had already done a whole bunch of work in the over the last years prior to start as far as payment initiatives going in the right direction for telemedicine visits. They had already done all that background work, so they, of course, knew exactly who to talk to in the local in the state government to try to help get this stuff passed and get it changed and stuff. So we did contact our local legislators, so our local House of Representatives and senators, and even in the corresponding counties for us to help get them on board so they could go back to the Capitol and lobby for us to get this done and help us get these laws rewrote to allow the programs to even exist in the first place. So while we were talking through this and working through this, we knew that it wasn't just the physical health of the kids that we needed to be paying attention to, because, looking forward, 5, 10 years, we in talking with the schools too, we knew mental health was a big piece of this, that while we didn't look as our organization to provide those services, we knew that probably 5 or 10 years down the pipeline, and again, this was pre-COVID. But just trying to look ahead and figure out, within the healthcare system, what could we use this for? Mental health come up in that. And so when we were rewriting those laws, we made sure to include the mental health language in there for future use, in the event that something come to fruition where they could start doing telemedicine mental health visits in the school. So funny, 6 years down the road, kind of how that's progressed and stuff. So we honestly didn't plan for that, but it did happen. And so we were glad we put that in there. So again, we started that process as far as the legislative hurdles in January or February of 2018. We were extremely surprised and ecstatic because as we worked with the Telehealth Alliance of Oklahoma, and then our legislators, again, boots on the ground, and they just lobbied for us more than we could ever ask up at the Capitol. But it was approved in the House and the Senate with 100% approval rate on both sides, from every legislator that was in there. And then it was also signed into law by the governor in May of that year with an emergency clause, which allowed us to start the program in August of 2018. So I don't know about you guys' states or how well y'all's House and senators and Democrats and Republicans get along in your state, but y'all will probably know this is very difficult to get something like this passed, especially when it's child-based. But it's very difficult to get something like that passed, especially with 100% approval in the House, the Senate, and then the governor agreeing to sign that into law too. So I'm not sure about y'all, but I really don't know of any other time that that's happened too much. So a big win for us for sure to be able to get that through the first time. We really anticipated this taking around 5 or 6 years to push it through, because we know it seems like it takes visit after visit after visit to get the legislators educated enough to where they finally agree to the program. But we were very fortunate that this all just went through pretty easily for us. So once we got that changed and just looking into the program, again, this was pre-COVID, so hesitancy of the guardians was a big piece of this. So some of the comments when we first launched the program, we received some comments on Facebook, of course, that, I'm not going to let my child be seen by somebody on TV that I don't know who it is or anything like that. So really overcoming that barrier was imperative that they knew that we weren't. First off, we're in the community. We're not a stranger. We're here to provide care, and we're here to help the parent as well as the student out. Another program goal with this was to keep the parents at work. So we have a lot of um, factory jobs. And they're very much 3 strikes and you're out, and you have to get a new job. And so we all know our kids don't get sick at the same time. So one might get the stomach virus, and then the next one get the stomach virus, and then the next one get the stomach virus. And so to keep those parents at work, we were trying to work on this program too. So it was just more of as long as we had their consent, it was just a phone call to the parent. Hey, Johnny's sick. Do you want him seen on telemed? Yes, I do. Thank you. And then we start the visit. So that was nice. But just education of the guardians, education of the parents, was very important in this. A lot of people knew about telehealth visits where you just call the doc on your phone and you can see a doctor that way. So we really had to educate the difference between telehealth and telemed programs and what we were doing. And our visits were honestly a better assessments than just seeing somebody on your phone and then them sending you some medication in, because you might not need an antibiotic if it's a virus or something like that. So education of the community was really important. And then probably our other biggest development challenge was school nurse buy-in. So, and of course, this is instrumental in success of the program. We provided education and we do annual competencies with our school nurses to ensure them being comfortable with doing the tests and processes of the program. So we do strep testing and flu testing on site. We provide the kits for the nurses and they just keep them in their office. And then if Susie Q, she comes in, she's got big red tonsils and complains of throat pain, they put them on telemed and we do a visit and they can strep test in the office and we know whether they're positive or negative within 5 minutes. And so either we don't send medicine in or we do. And so we send it to their pharmacy of choice and then mom or dad can go pick up their medication and then, within 24 hours, she can be back in school. So, but we had some nurses that really picked up on this and were great advocates for us. And then we had some other nurses that were like, no, that takes too much time. I don't want to do it. And so if you get those nurses, they're not advocates of your program. And so they're not going to promote it. They're not going to market it. And so that school is going to fail most likely. So, ensuring buy-in from the beginning for those nurses, for the school nurses is really important. One thing that we wanted to push is that we did not want to make the program cumbersome for them. If it's too hard or it takes too many steps, they're not going to do it. Those ladies are busy, 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 busy. Lisa can kind of tell you how busy they are here in a few minutes. I know when we go to see our nurses, we can't even hardly talk to them because they have kids coming in their offices all the time, all the time, all the time. And so they're very busy people, and we did not want to increase their duties or make it cumbersome for them. So that was one of the things that we really pushed to try to make it as easy for them as possible. And it was important for us to get that done for them, so we didn't cause them any more problems. Okay, community partnerships. I think we're going to talk about that one in just a few
Well,
minutes with.
yeah, we'll address that when we talk about the panel. And before we'll move forward before we move forward with Lisa's too, you can go ahead and talk about some of the um, operational challenges, technology. And I encourage everyone from the audience to please feel free, hopefully we'll have some time at the end. The plan is to have some time for some of your questions. So if you are experiencing challenges similar to what Tiffany's talking about or other challenges, we'd love to hear what those challenges are. And then maybe Tiffany and Lisa and Tom, we can all address maybe how we can help you overcome some of those, because pretty much sure, Tiffany and Lisa have scaled their programs quite a bit, so they've probably come across some of the similar challenges. So please feel free to enter some questions in about your challenges, and let's see if we can help you find a solution. Go ahead, Tiffany.
So on our technical and operational efficiency, our IT partnerships with the school are so important with this. Again, we try to streamline it as much as possible, just like our school nurses. Try to make it easy for them. They're busy. Lord knows they have so many teachers and students and tablets and things that they have to keep up with. We didn't want to add to their burden. So we were able to, of course, we installed some software that allowed us to remote log into the system. So if we do have trouble with our stethoscope or our otoscope or the software system not working very well, we just contact our IT. They remote in, and usually they know what it is, and because we've done it before. So they log in, fix it, and then we're able to continue the visit. So it really doesn't take too long. Our IT is very responsive. They know this is very important for us. We also prioritize these patients actually over their patients in the clinic. So if we know we've got a telehealth or a telemed visit coming in, we will jump on there and see that patient and then go see the patient in our office. So, just trying to, again, speed that up, not take time for our school nurses, because we want to streamline that as much as possible. But just a good working partnership with the school IT, our personal IT, and making sure that the software and the program's working well. Uh, Basically, kind of what we depend on the school's IT for is if it's a specific internet issue. So if the speed is not what it should be or something like that, then we'll rely on them, because they're the ones that can control that side of it. But honestly, that's about all that we ask of their IT on that, and they appreciate that, I can assure you. Our school nurses, partnership with it. So again, it's imperative to have their buy-in, starting and putting the work in at the beginning so they understand your goals, of your program and what you're trying to achieve and how it can help them and how it can help their kids. Um, they're those kids are their kids, and so they really want to do whatever they can for them, and they know which ones need help. So they're able to be your promotional person with that too, and say, hey, let's get Johnny a visit. He's been sick for a week. So sometimes they can be the one to talk mom or dad or grandma or grandpa into go ahead and doing that visit for that kid, because we all know if we don't feel very well, we're not going to do well at school, we're not going to do well at work. So we want their physical health well so they can do well with their mental health and then also their educational health too. So it all fits together with it. But again, the school nurse, you can't stress that enough with it. And if you put all your education and your time in on the front end and have them understand and make sure that they're comfortable with the process and the equipment and the testing and all of that, then I mean you're golden from there. Training wise, so this was a big piece too. So just education and communication with that. So we really worked hard, to have an open door policy. So all of the school nurses had my cell phone, and then they would just text me. And sometimes they would like, hey, I don't think this kid fits a telemed visit, but what should I do with them? And I'm like, okay, well, talk me through this. And so it wasn't even necessarily one of our telemed kids that we talked about, or, it wasn't really the visit that we were concentrated on versus as much as getting the kid where they needed or what they needed to do with them. So kind of that open door policy with those school nurses and being available to them, and again prioritizing their visits over some of the other visits just to ensure that they were quickly on and off and be able to continue their day. Um, so in just making those personal relationships with them too. So we would go out to the schools and take them good. It's always nice to get a nice little coffee or some snacks or something like that. Just, hey, is everything going okay? So that kind of falls into our marketing side of it, but a coffee and a cake pop sometimes goes a long ways. And so our school nurses appreciate that. They like those little snacks sometimes, and sometimes they have the snacks on their desk and the little kiddo comes in and snatches it. So, but just those marketing things of getting it out to the community. We typically attend all the open houses at the beginning of the school year when the students come in to meet their teachers. We try to be there and educate some of the parents on the telemed program. But we also make sure that we hit those kind of pre-teacher meetings. They have a few days before school starts that they go to some education stuff. So we're usually there to speak at those programs at the school so we can make sure that all the teachers are aware, because they're a big advocate for us too. So if they can, if nothing else, send them to the school nurse, and then the school nurse triage and decide whether they need a telemed visit or if they just need to go home or something like that. Just kind of leave it to the nurse, but really enlist that nurse on what it is. But and then also, we have a good relationship with the schools that they have allowed us to post some basic advertisement on on the school websites. We're on their little ticker. So, all of them have those little ribbons and stuff. And so our telemed every fourth round, I guess, the telemed program pops up for them so the parents know, because we know the parents don't always visit our hospital site, but they're always on the school's website or Facebook page or something like that because they're checking to see what's going on. So using those marketing techniques to help get the information out to the students, or to the parents, to let them know about our program. And then also we've kind of taken the stance of we don't care. I mean, of course, payment is important, but we want the kid to be seen. So we are a county facility. We're here to serve the citizens of the county, and we are a nonprofit. So our goal is to get that kid seen. We will worry about payment later. And if they are unable to pay for their visit, then we eat the visit. But that's just kind of our stance of when we started the program, because that was the purpose, is to be able to help those kids who may not be able to get the traditional help that they need. So.
Great. Thank you, Tiffany. It sounds like it's, as you mentioned, it's a continuous process, and it's constantly marketing and training and staying on top and having your champions kind of move that.
Absolutely. We have, and one thing, they have a lot of school turnover too. So the teachers may not be the same teachers as last year. So just constant education is important.
Great. All right. So before we go into Lisa's, thank you, Tiffany. That was great and super insightful. And we can ask, again, everybody type in their questions and feel free. We'll address some of these after. And I have some really good questions for Tiffany and Lisa as well in their program. So, all right, we're going to just quickly check in with you guys again and launch another poll about to try to understand which stage best describes where your organization is in expanding your telehealth program in the next 18 months. I know some of you said you're both have a telemedicine program or don't. Most of you do, just not necessarily in school. So this will help us get an understanding of how far along in the process and or stage you are with expanding your program. Okay, and we'll go ahead and end the poll. And it looks like, for those of you that responded, one of the options was not expanding, and that was 0%. So that's good to see. So everybody's either planning, implementing, or scaling. We have 21% of the audience said that they're in the early stages of planning and exploring. 36% have already started implementing and expanding the program. And then another 43% have an established telehealth program. So that is excellent to hear. Thank you. Okay, and I think you're done sharing. We're done sharing the results. I just want to make sure everybody. All right. So now we're going to move on to Lisa Patch, who's going to talk about her program at Alamogordo Public Schools, New Mexico. Lisa.
Thank you, Carrie. So now I'm going to take you from Oklahoma to Alamogordo, New Mexico. We're about 80 miles from the border. And let me tell you a little bit about our why. So I'm looking at it from the school perspective. And we're in a community. We have 14 different sites. And we have 24% of our children that are at the poverty level, and 22% of our population is disabled. So our program didn't start until after we were mid-COVID. And so let me go and show you a little bit about what we got during the COVID times, and at a time when the schools had a little extra money to focus on different things. And so telehealth became one of our interests. And so if you want to go ahead and go to the next one, I can show them kind of what we decided to do. So out of our 14 sites, we are fortunate we have an RN and a health assistant at every school. And so we were in a place where we were able to focus on how can we help our students more. With the poverty level that we're at, we have many families that don't have transportation. And especially during COVID, we didn't even have kids at school. So we started looking at how we get to the children. And so you can see what we endearingly call Flo. That's our mobile unit there over on the side of the screen. We call her Flo for Florence Nightingale. And just like Tiffany, we were thinking of medical help and mental health, and started taking her out to the skate parks and starting looking at what the kids needed, make sure that they had their Chromebooks and all the things that were going on during COVID. But during that time, we realized we needed to have more support for all of our schools. We looked at school-based health centers, and I know our neighboring community does have a school-based health center. We ended up working with an urgent care to be our end of our telehealth, and the community next to us linked it all to their school-based health center at one school. They linked all their units to that. So there's many different ways of doing this. As far as transportation, our nearest towns, if you've ever been to New Mexico, there you can go 80 miles and not see another person or town or house. And that's kind of where we're at. It to the next biggest town is 80 miles. And so we also have issues with getting to specialists. So the school district purchased the units, and which allows us to connect not only with our local urgent care, but if a family were to need to connect with a specialist in another town or something like that, we can do that as well. And working with the families to make sure that they have the needs met. We bought some of the what we call the 007 units, but it's really the very portable ones in the suitcase, and those go on flow, and we can take those out wherever we need to be. I think as Tiffany was saying, getting the information out, getting the training available, we started off the bat with once we purchased the units, then all summer long we provided the resources for nurses to come in and stipends to come in and just play with the units and to make sure that our connectivity was in place. We hired a telehealth technician just so that he could go out to the school sites and build that confidence level with the nurses, and also make sure if we had any technology issues that he was right there. So, and we have a float nurse available. So many of our schools will see 60 kids a day. And so asking them to do another visit, which it invariably it does take some time. So they can go to the school if the nurse needs them to, and do the visit for them if the nurse is busy at the school site with multiple children. So we wanted to make sure we had all the bases covered, had the nurses as comfortable with the process, and so they're able to get the kids back to class. The nurse's main focus when we started telehealth was they repeatedly see the same kids in the office with conditions that, they would send home a note, hey, please take Johnny to get this rash checked. And repeatedly, the child would either be out of school for multiple days after that, or they would come back and they'd still have the same rash. And we were going around in circles. So even though it does take time for a telehealth visit, if you start looking at the amount of time of the multiple phone calls we were making, this at least has a positive end result and keeps kids in school. So next was the processes and how we get everything done. And I saw by the poll that many of you are already in this process and have your own things developed. But I can tell you a little bit about ours. Our eligibility really was focused around which kids can we keep in school, which ones can we not have to worry about multiple truancies, which is a big factor for all schools right now, and keeping kids in school. So we started looking at those kids that have the rashes that, who knows what they are, the funky rash, should they be at school? Is it contagious? And so it's worked very well for that. Our process is that at the beginning of the school year, we get all the paperwork signed by the parents of who want to participate in telehealth. So we have that on file already. Then once they get to a point where they need a visit, then it's a quick text message to the parent to fill out any updated medical information. And then we have the doc on the screen, and the nurse has already gone through our protocols and standing orders. So if whether we do a strep test, an RSV test, a flu test, or a COVID test, those are all done before we get the provider on the other end of the phone, and as well as taking any pictures of the throat or things like that we might, or a rash that we might want to do beforehand. So ours is taking about 45 minutes now from the time we notify the parent. And in our community, the families did have some hesitancy and still do. And so we do say that at an appointment, the parent has to be available on the phone during the appointment to answer any questions that we may not be able to answer. Or they can be, of course, at the site. with their child. We've had very good response from the families that do it. And because we're a little bit newer, this is our second year, we're still working through exactly what telehealth is. And so we've also put together some videos that we send home to families about what telehealth is and what telehealth isn't. You know, we're not gonna do a telehealth visit for a head injury or a possible fracture, you know. So we want to make sure that parents know what they can or can't expect from that. The technology setup checklist, we found that it's just really helpful to have a checklist for the nurses every day when they come in, make sure their equipment is up and ready to go and working. So we developed a checklist for them to do and make sure that they're ready. And then the timeline for the visits, making sure that that communication is going back and forth between urgent care and the nurse, where we're at with the process, when the parent's ready, and making sure that we don't keep the kiddos in the health office too long before it gets busy with lots of other kids. The assessment part of it, of course, we're really just looking at what are the ones that we can keep in school. But I can say that as we've progressed and become more comfortable with doing the assessments, nurses have asked me, can we do more students than the ones that are just going to be possibly kept at school. So the nurses have chosen to expand on some of those symptoms, even if they know they're going to have to go home, but they know they don't have the transportation to get to urgent care or to a medical provider. Then we've expanded that as the nurse is able. I think one of the concerns that we had at the very beginning was that all the parents would just send their sick kids to school and tell them to go straight to the nurse's office, and then boom, now we're in urgent care. And so I haven't seen that happen, honestly. I think because we did start off slow and very specific about what we were there for, that part has gone really well. And parents are beginning to really see how we can be of benefit. And we do also have a military base here. So it has allowed us to be able to do an urgent care visit with the parent on the other end, and they're overseas. So they've been able to participate in a way that they wouldn't have been able to had we not had this. So there are some unintended benefits, I guess, to the program, as well as parents that are traveling out of town. We can still do a visit. It doesn't matter where the parents are at when that happens. So they can be out Christmas shopping in a nearby town and step aside and do this visit. So it's gone well for the families, and for the families that don't have transportation, we, like Tiffany said, we've been able to use the pharmacies to do deliveries for medications. And it really has, I think, helped us to keep our attendance rates up. And so it's been worked well for us. We're still continuing to work out the bugs, but it's been a really positive addition, and allows us to use the RNs as RNs in the schools, and really getting the benefit of having an RN in the building to be able to work to her level of expertise.
Great.
Thank you.
Thank you, Lisa. That was extremely insightful, and it was actually good to understand the process. I know, the audience today, there are people who are further down the path, but I think everybody can learn from the different things that you're doing and from each other. So I think it's really helpful for people to kind of walk through that process. Okay, so before we dive into our technology things to think about section with Tom, I'm going to just launch one other poll to understand what your level of technology expertise is. So what is your level of expertise with telehealth technology? And I know I want to be conscious of everybody's time. It's almost 3 o'clock, and we have some time left for panel discussion, which we will probably have to keep short. So we'll just do the best we can to address everybody's questions and get some discussion going. And then we will provide follow-up with the slides and a link to the recording, and of course, contact information if anyone has additional questions for any of the panelists. Okay, so we're gonna end the poll and share the results. It looks like, so in this audience, about 50% of you are intermediate with technology, so have some experience, 21% are beginner, and almost 30% are advanced. And nobody said they had no involvement. So everybody has some technology expertise. Majority is intermediate though, Tom. So hopefully that will help you.
That's good. That's good. Thank you so much. So Carrie and Amy, thank you from AMD for letting me join. And I'm just absolutely in awe with what Tiffany and Lisa are doing in their communities. I'm Tom Kemp and I work with Solutions. We're a nationwide integrator of AV technology. And we're really getting more and more into the telehealth market and helping companies like AMD distribute and also at times build their technology out for the individual different communities in which they are looking for us to assist. So one of the things that I'm just quickly doing is going to go through a readiness checklist, a telehealth readiness checklist, to try to just talk a little bit about that. And that is that these are just things that you need to kind of keep in mind as you're building out a presence within your community or your school. So first thing is to look at what your existing network broadband or bandwidth connectivity is. Are you going to be deploying carts that are plugged in, or are you going to have them truly mobile and have them hooked up to wireless? So there's all sorts of things that you need to consider about that. And you also need to think about how are you going to physically plug in these units? Are they going to be something that is going to be powered with AC, like just regular electric, or is it going to be something that is battery operated? So those are the kinds of things you need to think about as far as network broadband connectivity goes. Network security, I won't touch on this too much because most of the time network security is something that is pretty well in hand. But if you are doing and diagnosing patients, you might want to consider and make sure that your network is HIPAA compliant or EPHI compliant, if you will. Something that just makes sure that you're not going to be, accidentally, sharing information that you really shouldn't be outside of your community and your network. Redundancy and reliability. This is something that comes into play sometimes when you're looking at different grants. FDA and FEMA. FEMA, as an example, often will give money out to a community if you can build in some redundancy for telehealth within your community. So if you're deploying carts and you need to have, something that is ready and available during a disaster, do you have batteries in place? Do you have power sources that are alternative, like natural gas and those kinds of things, besides electric for generators and things of that nature? And then one of the other things that kind of goes along with that is when you're looking at doing your deployment, what kind of hardware do you need to have in place? Software do you need to have in place as well? One of the things I think that often gets overlooked is the training side of how to actually use the new equipment that's just been deployed. And so if you're a 4-year or a 2-year college, are you going to use your learning management or your content management system? If you're a healthcare provider, or for that matter, a K through 12, if you're a healthcare provider, are you going to use some of the healthcare or HR systems that are in place just to do basic training within your area? Are you going to rely on Epic to try to help you with doing some of your training as far as that goes? And then from a standpoint of what I saw everybody saying just a moment ago is you're all kind of building or starting to build your mobile presence, your mobile telehealth presence. And so scalability and future proofing is something that you should probably start to think about right off the bat as well. Sure, this is phase 1, but what am I going to do in phase 2 and in phase 3? And not being scared to go and say, you know what, this particular piece of equipment, this legacy piece of equipment I have in place, maybe it's time to go and put this to bed and not include it in what I'm about to build and create. That's often something I think that is something to think about as you're going and building out your system. And then from a standpoint purely of integration, there are basically 6 different phases to build out an implementation of your telehealth presence. So this is kind of my simple little checklist. Just phase 1 is engineer and design the system so that everybody is very clear on what it's capable of doing, how it's going to be done, what technology needs to be in place in order to make it work. And then essentially, obviously, you have to go through the procurement process, ordering all the gear. That takes usually between, anywhere between 6 to 3 months, 6 weeks to 3 months to get that done. And then start the actual testing of the configuration, making sure it's going to do what you plan it to do. And then the implementation process sometimes can take several months, getting it in place and testing it, and then testing it again. And then as you're building and scaling, testing it again. And then just the simple closeout process of, is it doing what we need it to do? What training do we need to put in place that we hadn't thought of? Those kinds of things, getting that done. And then making sure that what the integrator has built for you is also something that is able to be supported and maintained. And what's the plan for that? So that's kind of my 6-phase little implementation list of how you go about that.
Thank you.
And then, and then last but not least, I'll just very quickly say, don't be afraid to ask our new AI colleagues on how to do something. I myself am using DeepScribe in regard when it comes to going and I will go and I will ask the AI technology, what is it I'm forgetting? With this deployment within these parameters, I'm a 4-year college. I have 1 main campus with 5 far site campuses. I want to deploy this system with being able to do these kinds of clinical comprehensions. What am I missing? What do I need to ask my integrator to make sure that this is going to be successful? So using the artificial intelligence that is out there now, these 5 here are all specific to healthcare. So don't be afraid to ask those, because I'm starting to use it, and it's amazing how I'm able to drill down and ask better questions of the people I'm trying to help.
Great. Thank you, Tom.
You bet.
That was super helpful. And like you said, even though people, whether they're at the beginning stages or middle or end, I think reassessing the technology is very critical. I know we've seen, people get the technology and years go by, they may use it, but there's always new things, new updates and new, software updates and things that change over time. So reassessing that technology and using, a lot of times you can use what you have. I mean, it doesn't hurt to use the infrastructure you have, the technology you have, and see how you can add on to it. But certainly need to do an assessment checklist before you assume that it works or that everything's going to be integrated. Okay. So we are going to jump into a panel discussion, and I know we're coming close to 3 o'clock. So we will, I'm looking to see what questions we might have we can address. I know some people have asked questions, and I believe some of our panelists have gone ahead and addressed them in the question box. So one quick question to lead us into the next panel discussion is about partnerships, community partnerships and funding. So I'd like to just launch a quick poll again to get your feedback on if you're looking for funding for your telehealth program or to expand your telehealth program. We know obviously most, pretty much all school-based telehealth programs have some sort of grant funding or funding that's available. There's a lot of funding out there. So of course, everybody says yes so far. Funding says yes. We'll share the results in a moment. Just give you a few more minutes. Okay, we'll share the results. Everybody said yes. No one's going to say no to money. Okay, so we'll go through some of the discussion points here. Just want to invite the team back here. So to kind of follow up on that, I know, Tiffany, you have some really interesting and unique ways that you got your program started with the partnerships, and obviously are continuing to work with those partnerships and or funding. Can you maybe talk a little bit about what you've done, partnerships within the community or funding, and then we'll also move on to Lisa to hear what things you've done.
Yeah, so ours is a little out of the box. It's not your typical grant fundings that most people think about on how we got our program started. So you can see in the comment section, our board members were instrumental in helping us get this. So they helped us secure some financing, and it basically the local banks gave us money to buy buy the equipment to install in the schools. So our first school, the school actually bought the equipment and we supplied the nurse. So it's a little bit different model than the second school that we did. The second school, we provided the equipment because they already had their school nurse, and I think they bought they had the mobile unit already, so we really just bought the equipment piece of it. So that one was different than the first one that we did. And then the next four, a local bank came up and supplied the money for it. So they bought 4 units for us, and they had strategic locations that they requested they be in. It just happened to be in the same towns that their banks were in. But we were happy to put them there because they were buying the equipment. So that we got money that way to get those. And then there was a couple of other ones where it was local civic organizations joined forces with a couple of local banks in that town, and they bought the money, or they bought the equipment for that school. And then we had another one that was it was actually an insurance agency, and then our electric co-op put their funds together and bought the equipment for that school. And then most recently we have had it's a grant that another college applied for on the other side of the state, but part of the agreement was that we would help them get their program started, and they would buy us 6 units. And so that was kind of a non-traditional grant funding, I guess you could say, because we really didn't do anything. We just were more the recipient of it on the grant side of it. And then our last one is our state college that we've just recently added. They had some extra COVID fund money that they needed to spend by the end of the year, or something like that. So they were in a hurry to buy some equipment. And so this just really fit in with them because they didn't have a school nurse or infirmary for their college sites. And so this fit really well for them. So a little non-traditional funding opportunities, but if you think out of the box, you can figure out a way to get it done.
It's a good point, and it's very creative too. And actually, good to hear that funding, a lot of COVID funding is still, there's still a lot out there. In fact, someone just made a comment, one of from the audience, about digital equity grants coming out that can support telehealth. So that's something new that maybe some of you might want to consider looking into. Lisa, do you have anything to add on regarding grants and partnerships? I know you partner.
It was similar. Our first 4 came from a Medicaid insurance company, and then COVID funding, and then also, as Tom had mentioned, making that sustainable and bringing it into disaster preparedness. We were able to add the backup generators type things to support that for disaster preparedness as well.
Okay, great. Both of you kind of touched on some of, maybe personal stories or examples of where you saw telehealth really made an impact on an individual case or a student or family member. I know, Tiffany, to go back, you talked about some grandparents. I think you told me the story personally about, how the care affected an individual in a community and things you might not think of. So I don't know if each of you have a specific example that you can share with us or the audience of how the telehealth made a difference for a student or a family.
I can think of a few, but one in particular was a situation where a child was in need of medical care, wasn't getting it. The communication wasn't really happening, and we were at a point of it was either going to be a CPS referral or, and this was kind of the last opportunity, like, if you can do that. And that's when they disclosed that they didn't have the transportation to do what their child needed, and we were able to help them instead of going down a system that would not have been as positive results.
That's great. That's good. And those are some of the unexpected areas. And one of my other questions is if there was any, unexpected benefits that came. And that's actually a good example, Lisa, of things that you may not have planned or weren't in your goals for your telehealth program, but there are so many other benefits that take place that you didn't think of. Tiffany, do you have any other examples to share?
I do. So, one that really comes to mind was one of our schools that again, kind of like Lisa said, the nurse knew that the kiddo wasn't getting the care that they needed. But it was one of those situations where they just didn't have the money to take the kid. There wasn't a doctor in town. And they didn't have the money to drive 20 miles. I mean, we don't really think about that a lot of times, but they couldn't even drive 20 miles to come to Poto to see a physician or somebody, or go to the pharmacy and pick up the medication. So in that situation, the nurse kind of took it, and I was grandparents raising a grandchild, and they'd already missed several days of school, and over something very simple that can be treated, stick them on antibiotics and then be back in school in 24 hours. So the nurse arranged for the visit. We got the visit done. She immediately on her lunch break went to the pharmacy and picked up the medication, brought it back to school, kept the medication at school, so she knew the kid would get treated like they needed to. And so they took their medicine when they first got to school, and they took it before they left. And amazingly, they didn't have any more absences due to whatever was going on at the time. So some of these are just super simple solutions, but it's just having the access to be able to do it.
Yeah, that's a great example. Thank you for sharing. I know we're at 3 o'clock. I did have some more questions, but let me first address any questions that came up from the attendees, because we're close on time here. Let's see, it looks like they were answered. I know some of them you answered, Tiffany, was about, somebody was asking about if her program performed wave testing, flu, strep, COVID. If so, how is that being funded? So it sounds like that you do strep and flu testing on site at the school, and you applied for wave testing from CLIA for each school. Okay. Only other thing we can close out, I think we've addressed most of these questions. So I want to thank you all for your time. Thank you, Tiffany, Lisa, and Tom, for joining me on today's webinar and sharing your experiences. And thank you to the audience for attending. Have a good day.